What is lumbar stenosis? Hello, this is Dr. Grant Cooper at Princeton Spine and Joint Center. In this video, I would like to discuss one of the most common problems that I see on a daily basis. Lumbar stenosis is one of the most common causes of back and leg pain, as well as of numbness, tingling, and weakness in the legs. There's a lot to understand about lumbar stenosis, so let's dive in. Now, first of all, lumbar stenosis literally means narrowing of the lumbar spine. Specifically, it means that the holes where the nerves travel within the lumbar spine have narrowed, so there's now less room for the nerves to exist in those holes. Because of this stenosis or narrowing of the holes, there's then a greater chance that the nerves will become irritated and inflamed, which in turn can cause pain and other symptoms. The first thing to realize about lumbar stenosis is that a lot of people have it and don't actually develop any symptoms. Now, that's very important to recognize because it means that if you do have symptoms from lumbar stenosis, then you can then know that it's possible to make the symptoms go away and to live the rest of your life without those symptoms without necessarily surgically opening up the holes. Right? The narrowing of the holes in and of itself doesn't cause the symptoms. The symptoms come when the body responds to that narrowing with an inflammatory reaction. And it's then the inflammation that's resulted that needs to be eliminated in order to take away the symptoms. And we'll return to that soon. But before we do, let's talk for a moment about the holes in the spine that get narrowed and where they get narrowed inside of the lumbar spine. The stenosis can occur in one of two basic places. So here is a lumbar spine. This is the front, this is the back, so it sits like this. Now, the lumbar stenosis can occur in the middle of the spine where the nerve roots are ascending into the spinal cord, or it can narrow where the nerves are exiting the spine. When the stenosis is in the center of the lumbar spine, we call that central spinal stenosis. And when the stenosis is present where the nerves are exiting the spine, we call that foraminal spinal stenosis. Most people develop symptoms from foraminal stenosis, but it's an important distinction to make because some treatments will work for one type of stenosis, but they won't work for the other. Now, more on that in just a bit. But first, what actually causes the stenosis? Well, stenosis can come from many places in the spine. The most common reason that someone might have lumbar stenosis is a herniated disc, where the intervertebral disc over here has moved and is now making the holes where the nerves travel smaller. Another really common reason, particularly in older people, is something called facet joint arthropathy. And basically, you have these facet joints over here in the back of your spine. And facet joints are like other synovial joints in your body, like your knees, your fingers, your toes, etc. And you've seen how older people sometimes develop knobby fingers, like the joints in their fingers become knobby and overgrow. Well, the same thing can happen in these facet joints over here. And when that happens, in the facet joints, the bone spurs and the general bony overgrowth of these little joints then crowds the hole where the nerves are traveling, and it makes that hole smaller. Now, there are a host of other factors that can contribute to lumbar stenosis. One relatively common other factor in stenosis is that there's a large ligament in the back of the spine called the ligamentum flavum. And this ligament sometimes gets bigger and it can even buckle forward, which will then also put more pressure on the holes where the nerves travel. Ligamentum flavum hypertrophy is generally more common in central stenosis. What typically happens in older people is that all of these things start to happen to a greater or lesser extent, and the net result is that through a confluence of factors, the holes where the nerves are traveling just become smaller. Now, when lumbar stenosis causes symptoms, what are those symptoms? In the more common foraminal stenosis, the most common symptoms are ones that we would generally be associating with sciatica. So basically, the nerve becomes inflamed, and people then feel radiating pain into their leg. The pain is generally described as sharp or burning, but it can also be described as achy as well. Now, usually the pain is going to be worse depending on the position of the person. In people with stenosis that's coming more from the facet joints in the back of the spine, standing usually makes the symptoms worse, and bending forward usually helps take away the symptoms. Now, sometimes with facet joints causing the stenosis, the facet joints themselves will also become painful, and then the person may also have achy lower back pain in addition to the radiating pain in the leg. Now, in people with herniated discs, the mechanics are generally the opposite, where bending forward makes the pain worse, and standing and bending backward helps take away the pain. And here too, the disc can also cause lower back pain in addition to irritating the nerve, which is then causing the stenosis symptoms in the leg. Now, sometimes, in addition to or instead of pain in the legs, the person will feel numbness and or tingling in their leg. The symptoms in the leg generally follow the distribution of the nerve root that's inflamed. So, for example, if the S1 nerve root's inflamed, then the symptoms are usually in the back of the buttock, thigh, calf, and into the bottom of the foot. If it's the L5 nerve root that's inflamed, then the symptoms are usually in the buttock, the outside of the thigh, and the lower leg, and then the symptoms go into the top of the foot, and characteristically from an L5, the symptoms go into the big toe. If the L4 nerve root is involved, then the symptoms generally go into the front of the thigh and into the inside of the lower leg. The L3 nerve often refers into the inside of the thigh and the knee, and the L1 and the L2 nerves generally refer into the groin. With that said, it's important to recognize that these are good rules of thumb, but there's a lot of individual variation in how nerves present in any given person, particularly when the symptoms are pain and numbness or tingling. Now, sometimes the symptoms will include weakness. This follows a more typical distribution from the nerves. If the S1 nerve root's involved, then the person may have trouble standing on their toes on the affected side of the body. If the L5 nerve root is involved, then the person may have trouble standing on one leg because their hip abductor is weak, which causes hip instability, or they may notice a slight or not so slight foot drop. If the L3 or L4 nerve root is involved, then their quadriceps may be weak, and they may feel like their knee is going to give out. If their L1 or L2 is involved, then they may have weak hip flexors. When nerves are inflamed or injured, usually pain comes first, then there's numbness and tingling, and then maybe there'll be weakness. For doctors, the signs and symptoms that are most concerning in terms of the health of the nerves are true numbness and weakness. Now, when I say true numbness, what I mean is that the leg doesn't just feel numb to the patient, but when the leg is examined, the patient actually doesn't feel me touching them, right? So you feel the leg and they just don't feel it in the distribution of the involved nerve root. So that is, they've lost sensation to touch. This suggests more nerve root involvement than if the person feels like they have a numb leg, but they don't feel numb when they're actually examined. So for example, if they close their eyes and you touch their leg and they can feel you touching them just fine, this is a reassuring sign that the health of the nerve is probably better than if they couldn't feel you, for example. And with that said, weakness is the most concerning symptom from a nerve root being inflamed or injured. Weakness suggests that the nerve is very significantly impacted. This becomes very important when we think of how we're going to go about treating a patient, because at a certain point of damage, nerves don't get better. So you want to make sure that even if there are lots of symptoms, and maybe the patient feels really awful, we want to know that the nerves are healthy so we can focus on the symptoms. If the nerve root health itself, if the health of the nerve is in serious jeopardy, then it suggests that we might want to take a more aggressive treatment course, one that might even include surgery, because we just can't allow the nerve to get to the point where it won't get better. But if the health of the nerve is not too much in question, then we can go off the patient's symptoms in terms of how aggressive to be. One way to determine the health of a nerve is to get a diagnostic test called an Electrodiagnostic Study, or an EMG. So in this test, we're interrogating which nerve is affected and how badly that nerve is involved. You can think of a nerve as like a wire in the wall. There's the wire, and then there's the insulation around the wire. So in the nerve, there's the axon, which is the wire, and then there's the myelin that acts as the insulation around the axon. When a nerve is inflamed but healthy, it means the insulation is irritated and may be damaged, but the axon itself is healthy. On a nerve test, this will mean that the nerve fires slower than normal. This indicates that the nerve's involved, but it's not as serious in terms of the overall health of the nerve. On the other hand, if the axon itself starts to become involved, then the amplitude of the nerve on the nerve test will get smaller, and this will make us start worrying about the health of the actual nerve itself. An inflamed but otherwise healthy nerve can still cause horrific symptoms that can include awful pain, numbness, and even sometimes weakness. But the difference is that the health of the nerve is not in question. So then, in terms of how we go about treating it, it becomes more of an open question as to how aggressively we treat the nerve, and this will depend mostly on the symptoms and how the patient feels about different treatment options. When the health of the nerve is in question, it's still obviously ultimately the patient's choice as to how to go about treatments, but there is, or there really should be, much more of an urgency to the treatment in order to give the nerve the best chance of making a full recovery. So, okay, maybe that's a good segue now into how we go about treating foraminal lumbar stenosis. Again, foraminal lumbar stenosis is the most common type of lumbar stenosis where the nerves are inflamed as they exit the spine. And this would cause what you would also call a lumbar radiculopathy, or some might just say simply a pinched nerve in the back. Now recall that not everyone with lumbar stenosis develops any symptoms. In fact, after the age of 60, close to 100% of people have at least some degree of lumbar stenosis if you were to get an MRI to look for it, and most of those people don't have any symptoms from that whatsoever. Now with that said, lumbar stenosis certainly sets the stage for the symptoms. The symptoms just come when and if there's an inflammatory reaction to the stenosis. Now, inflammation is a protein response, but the best way to think of it in this context is that it's like a fire. And there are two ways that we can put out a fire. The first is to move away the gas, right? To clear away the sticks. You clear away the fuel to the fire and the fire just burns itself out. In a surgeon's world, that means surgery. It means literally going in and decompressing the spine in order to alter the anatomy and take the pressure off of the nerves. In the conservative world, which is really more of my world, moving away the sticks and the fuel typically means targeted exercise. It means physical therapy. It means training the right muscles to support the spine in order to take the pressure off of the nerves and just let them rest and heal. Sometimes exercises work really well to unload the spine and let the nerves heal on their own. Other times, that fire just keeps on burning, or there's too much inflammation and pain there in the first place to even do the exercises. Now, in these situations, it's often helpful to take a fire hose and put the water on the fire. Now, the best fire hose is going to be an epidural steroid injection. In this procedure, a needle is placed under X-ray guidance right next to the inflamed nerve root, and anti-inflammatory medication, which is the steroid, is placed next to the nerve. The nice thing about this procedure is that it tends to be very effective in taking away the inflammation and therefore also the symptoms in these situations. Now, let's take a moment to note that when we do this, it's not a Band-Aid, right? An epidural steroid injection is not a painkiller. An epidural steroid injection, when it works, is removing the inflammation, which is what is causing the symptoms. But the limiting part of this procedure is that an epidural steroid injection does nothing to address the underlying biomechanics that led to the inflammation in the first place. So if all you did were epidural steroid injections, they tend to give about 3 months or so of relief. Now, during those 3 months, and sometimes it's longer and sometimes it's shorter, but basically during that time, when the inflammation and the symptoms are better, if you do nothing else, then what happens is slowly the nerves tend to get aggravated again because we haven't addressed the biomechanics, and so presumably the same irritation that led to the nerve being inflamed in the first place is still there. So it's very important that if an epidural steroid injection is used, then it should really be used as a window of opportunity during which the patient can learn and perform targeted exercises to stretch and strengthen the appropriate muscles in order to unload the spine so that as the steroids wear off, which they will, the inflammation doesn't necessarily return. We have a video on the best exercises for back pain, and they're also excellent for this purpose, but so is working directly with a physical therapist. Now, once you're feeling up to it, I think an exercise routine such as Pilates can be an excellent additional way to continue to strengthen and stretch the right muscle groups to help keep you strong and limber and pain-free into the future. Sometimes, despite the best conservative efforts, the inflammation just keeps on burning. Or sometimes there's so much stenosis that the nerve is truly mechanically compressed, and in this case, it's just not going to get better with conservative care. In these instances, surgery can be the best option. Now, there are in fact two concrete surgical indications in lumbar foraminal stenosis. The first is if there's progressive neurologic loss. So if you're getting weaker and weaker, then surgery should certainly be considered to save the health of the nerve. And second, if the symptoms are severe despite good conservative care, then surgery should at least be considered. And when it comes to surgery, there are two basic types of surgery for this lumbar foraminal stenosis. So one is a decompression, and one is a decompression with a fusion. Now, to make the symptoms of lumbar foraminal stenosis go away, you only generally need to perform a decompression surgery in which the nerve undergoes essentially a rotor-rooter, a procedure where anything that's causing stenosis or narrowing, such as bony overgrowth or disc, is removed, so there's more room for the nerve to exist in the hole without being irritated. The trouble is that in some people, when you start taking away the bone, you can destabilize the spine. It's like a game of Jenga, where if you take away too many of the little pieces, you can jeopardize the stability of the whole structure. Now, if the surgeon feels that by taking away the stenosis, the spine may become destabilized, then the surgeon is going to have to fuse the spine as well as decompress the spine. Now, in the fusion procedure, the surgeon will typically put hardware into the spine. The difference between a decompression and a decompression with fusion is really huge in terms of operation time and in terms of recovery. A decompression alone can be a relatively short recovery with people getting up and about within, say a few weeks depending. Now, a fusion, on the other hand, can take 6 to 12 months before a patient is feeling back to themselves. So it's really a big difference from that standpoint alone, not to mention that a fusion puts more pressure on the parts of the spine above and below it after the fusion, because now the normal motion of the spine isn't able to go through the segment of the spine that's now fused, so other parts of the spine have to take up that slack, and that can lead to future problems down the line, something it's a phenomenon called adjacent level disease. Okay, let's turn our attention now and talk about lumbar central stenosis. In lumbar stenosis of the central part of the spine, the nerve roots as they ascend the spine are compressed in the middle of the spine. This doesn't tend to cause much pain, but it does tend to cause more neurologic loss, such as numbness and weakness. If the central stenosis is very bad, it can cause incontinence of the bowel or bladder, which is very rare, but it's also a definite surgical emergency. More typically, central stenosis causes symptoms that are similar to foraminal stenosis, but often they may be a bit more diffuse and more neurologic in nature. Now, the big difference in terms of treatment is that while physical therapy is still an excellent conservative approach, epidural steroid injections really aren't indicated. Epidurals work very well for foraminal stenosis, but they don't tend to work well for central stenosis. If central stenosis is severe and the health of the nerves is in question, then surgery really becomes a very viable option. There are, of course, other treatment modalities for both types of stenosis, both central and foraminal. Gentle chiropractic care can be helpful to increase the mobility in the back. In my mind, this works best when paired with good physical therapy exercises as well. Medications can help manage the symptoms of lumbar stenosis, but they won't help fix the underlying problem. It's important to recognize that only about 2% of oral medication actually makes its way to the spine. So taking anti-inflammatory medications can help with stenosis symptoms by reducing pain, but they won't generally be able to reduce the inflammation at the site of the nerve root. The notable exception to this rule of thumb would be if you took high-dose oral steroids. But taking enough oral steroids to significantly impact the spine will often cause lots of side effects and affect the rest of the body in a pretty significant way, such that an injection of a small fraction of that amount of steroid directly to where it needs to go in an epidural is generally going to be a better and more effective option. Now, there are also nerve membrane stabilizing medications such as Neurontin and Lyrica. These can be particularly helpful for some people with radiating pain, but they don't tend to work well on numbness, and they definitely won't do anything for weakness. And they do carry side effects. Most notably, they can affect a person's mood, and they also can make people tired, dizzy, a little loopy. People can have memory problems. It's worth remembering that most cases of lumbar foraminal stenosis are successfully treated with conservative care. Now, once the symptoms are resolved, no matter how you get there, surgically, non-surgically, therapy, injections, it's important to think about learning and doing a set of exercises and learning about the biomechanics of your spine so that you can keep your spine healthy far, far into the future. Okay, I hope you found this video useful. Please remember to like this video and please consider subscribing to our channel if you haven't already. As always, if you have any questions or comments or suggestions for a future video, then I'd love to hear from you in the comments section. Thank you very much for watching, and I wish you all the best of health.